describe the personality of a patient with PD. He was vegetarian, drank no alcohol, didn't smoke, and drank a decaffeinated coffee. So we can easily understand why he was so angry with everybody. But actually, the other interesting part of the story is that Dr. Morel treated Hitler with subcutaneous injection of armin, and armin is a monoamine oxidase inhibitor. It definitely was not selective, but definitely was a monoamine oxidase inhibitor, together with Homburg, which is actually an anticholinergic compound. So I would say that enzymatic treatment was probably one of the first treatment in Parkinson's disease, together with anticholinergic compound. And it is actually based on physiology. So just to remind everybody, I know that you perfectly know this story, but actually levodopa is formed by tyrosine. Tyrosine we eat every day with the food. It gets into the brain, is transformed by the tyrosine hydroxylase in levodopa, and levodopa is transformed by the dopa decarboxylase in the brain in dopamine, is stored in the presynaptic vesicles and released continuously to stimulate the postsynaptic compartment. At this point in physiology, normal brain, metabolism of dopamine is mainly due to the reuptake system and to monoamine oxidase A in the presynaptic vesicles. So at this point, the monoamine oxidase B play a very marginal role. And in fact, people working in the lab, they used to take selegiline every day just to prevent toxicity from MPTP, and without any pharmacological effect. So this is still the normal brain, so we have a flow of dopamine going down, stimulating the postsynaptic in a continuous way. But what happened in PD patient when the presynaptic compartment is lost? Together with the presynaptic compartment, the patient loses the DAT, dopamine uptake transporter. They lose the monoamine oxidase A in the presynaptic compartment. Now, the metabolism of dopamine is actually switched to monoamine oxidase B. And now the monoamine oxidase B in the glia start to play a very important role because it metabolizes dopamine. Now if we block MAO-B with the monoamine oxidase B inhibitor, then we can increase the dopamine in the brain and we can improve symptoms of patient with Parkinson's disease. This is another figure showing you in a different way the same concept. You see that dopamine is metabolized mainly by the monoamine oxidase B in the brain, forming DOPAC, which can be measured, or on the other side by COMT, which actually formed the 3-oxymethyl DOPA in the brain, and monoamine oxidase B again metabolized to HVA, which can be detected in the CSF. So, based on this concept, the first generation of monoamine oxidase B was born, and the first one was selegiline. Selegiline is an amphetamine derivative and possesses indirect amphetamine-like sympathomimetic action. It is actually a very active, potent monoamine oxidase B inhibitor. And the first important study with selegiline was the DataTop study published by Warren Olano and the others in 1989, and they actually showed a very clear effect of deprenyl or selegiline in early patients with Parkinson's disease. This was intended to be a neuroprotective trial, but eventually come out to be a clear measurements or a clear evidence of symptomatic effect of selegiline. This is another study which was published in 2008, a long-term study, selegiline versus placebo, again showing in early patient, de novo patient, a very clear symptomatic effect. But selegiline, unfortunately, has a number of side effects because of the amphetaminergic metabolized, and it may cause insomnia, cardiac effect, and is not very selective. So a second generation of monoamine oxidase B come out and has been used and is still used in the treatment of Parkinson's disease. Then we're talking about rasagiline. Rasagiline is a potent selective monoamine oxidase B inhibitor. It can be used in early and advanced Parkinsonian patient, and it actually hasn't got any metabolites that can induce side effects. In different trials, this is the TEMPO study in early patient, rasagiline showed to be symptomatic efficacious, reducing the UPDRS, total UPDRS by about 4 points. But the other interesting aspect of this story of the enzymatic inhibition is a lot of people really cannot quantify how effective, how strong is actually monoamine oxidase B inhibitor. Well, and I hope this slide help you to find out. So on one side, you see the L-DOPA trial with the different dose, and on the other side, you see the TEMPO study with rasagiline. So if you see the improvement induced by 150 milligram of levodopa here, which is about 2 points improvement in the UPDRS, not versus placebo, of course, but versus baseline, you see that it's very similar to the improvement induced by rasagiline in early de novo patients. So I would say that in early stage, really early patient, rasagiline symptomatic effect can be similar to 150 milligram of levodopa, more or less. And the fact that these drugs are efficacious in early stage has come also out from other evidence. This is, for example, again, another double-blind trial, which is the Adagio trial. And you see that the patient treated with placebo received much more and much earlier rescue therapy compared with the group treated with rasagiline. So that means that the patient on rasagiline and the doctor looking after them, they were happy how the patient was doing, and they didn't consider another symptomatic rescue therapy versus the other group taking placebo. So these drugs, they do have a symptomatic effect in monotherapy in early patient. I underline early because, as I showed you, this drug to work without other compounds such as levodopa, they need some dopamine in the brain. So the patient has to be in the early phase so that still have some dopamine in the brain and the drug can work. If you use monoamine oxidase B in a more advanced de novo patient, probably you don't see much because of the lack of dopamine in the brain. What about in more advanced patient? Here we have more evidence. Why we need enzymatic therapy in more advanced patient? Because as Peter just told you, levodopa has a number of limitations despite remain the best drug in the treatment of Parkinson's disease. The main problem is the short half-life. Levodopa combined with dopa decarboxylase inhibitor has a very short half-life. It's about 1.5 hours. Levodopa, only a small percentage of levodopa reach the brain. It's actually increased when you give levodopa with dopa decarboxylase inhibitor, but still a large percentage of levodopa is lost in the periphery. It does not prevent motor complication, but indeed induce or worsen motor complication and induce early wearing off. So levodopa has a number of limitations. In the last, I would say, about 30 years, we tried to improve levodopa with different system, either changing the formulation of levodopa, as Peter just showed you, or using other drugs that actually can help levodopa. And the levodopa, the short half-life of levodopa is probably the first or the main factor inducing motor complications and probably dyskinesia in PD. This is David Marsden, who actually described for the first time on the Lancet on-off phenomena in patients with Parkinson's disease in 1976. And now we know that fluctuation can be a very early phenomena. And this is a study conducted in Italy, and where we show that wearing off phenomena is present in 42% of the patients within 2.5 years of disease using a questionnaire, but also using a classical standard doctor visit. We found 22% of patients within the first 2 years of disease suffering already from fluctuations, wearing off phenomena. The other aspect that we learned in these few years, this is the post-hoc analysis of the STRIDE PD study, which actually showed that the risk of dyskinesia and wearing off increase enormously when you give more than 400 milligrams of levodopa per day. So there is this sort of magic threshold, and if you remain under 400 milligrams, probably motor fluctuations and dyskinesia appear with more difficulty, or they appear later. So considering all of this and going back to our cartoon, we can actually increase the amount of circulating levodopa, blocking the other metabolic pathway, which is the catechol-O-methyltransferase. So if you block the catechol-O-methyltransferase using a catechol-O-methyltransferase inhibitor, you have more levodopa in the blood, you have more levodopa in the brain. So now you have more levodopa than the patient can use, and for longer period of time. So this effect of and of course, sorry, I didn't mention the other aspect, which is important. And if I block in the monoamine oxidase B, and I'm giving exogenous levodopa, so I'm giving levodopa as a therapy, I can still increase the half-life of dopamine in the brain, and I can have more dopamine in the brain. So COMT inhibition in the periphery to increase the half-life, monoamine oxidase B in the brain to increase the dopamine half-life in the brain and reduce metabolic pathway. And in fact, if you look at the Largo trials, the European Largo trials, where we compare rasagiline and with entacapone and placebo, you see that the effect of rasagiline and the effect of entacapone are very similar in terms of reducing off time. So monoamine oxidase B in the brain, catechol-O-methyltransferase inhibitor in the periphery, they produce a similar improvement in terms of reducing off time. So COMT inhibitors, why that? I already told you, because levodopa is metabolized by dopa decarboxylase, and we inhibit dopa decarboxylase with benzerazide and carbidopa, and catechol-O-methyltransferase and can be inhibited by COMT. So blocking the COMT increase the half-life, increase the pharmacokinetic of levodopa. This is my study, PK study with tolcapone. Tolcapone was the first drug used to block catechol-O-methyltransferase. It was a very potent catechol-O-methyltransferase enzymatic blocker. And as you can see here from this plasma profile, you see the increase in plasma profile when tolcapone 3 times per day was added to standard formulation of levodopa, which is the violet line down here. And this patient was taking 4 times per day levodopa 100 milligrams. So tolcapone was definitely very efficacious in changing the plasma half-life of levodopa. And this was transformed in an improvement, quite dramatic improvement in off time in patient studied. So these are the 3 pivotal trials, all of them showing a very good improvement in off time during the day. Unfortunately, as you know, tolcapone has been withdrawn and then is now back on the market, but we have to monitor the hepatic enzyme because of liver toxicity, and so it's marginally used only in a few number of patients. This is the other one. This is the second generation. Is the entacapone. Entacapone, it's actually another inhibitor of catecholamidyl-transferase. It's not as potent as tolcapone, but it hasn't got any hepatic toxicity. And in the plasma level, you see that it can definitely improve the half-life of levodopa and increase also the Cmax and the area under the curve when added to standard levodopa. And in this PET study, you see that when carbidopa-levodopa is combined with entacapone, remain in the brain for much longer time, and also you have more levodopa getting into the brain. Again, entacapone showed to be efficacious in reducing off time. So entacapone is another drug that reduces off time in fluctuating patients. The one showed in these slides are the pivotal trials, or going in the same direction, so showing a clear reduction in off time and increasing on time. What about early morning akinesia? Why I'm showing you this slide about early morning akinesia? Well, not just because we did a study on that, but because nocturnal akinesia and early morning akinesia impair quality of life of our patients. So how this enzymatic inhibitor works on nocturnal symptoms and early morning akinesia? Well, from this sub-study of the Largo, which is where we measured the severity of the practically defined off in the morning of our patients. So that means that you take the patient early in the morning before taking any other dopaminergic treatment, you measure the UPDRS. You see that the patient treated with rasagiline, they had a very good improvement in practically defined off in the morning compared to placebo, but not entacapone. So that means that the monoamine oxidase inhibition is actually longer than the catecholamidyl-transferase inhibition induced by entacapone, which has a very short half-life. So entacapone increased the half-life for levodopa of about an hour, but is not enough to cover the night, whereas the monoamine oxidase B can actually increase the dopamine throughout the 24 hours and giving an improvement the following morning. There is also there are other important aspects. Fatigue is another symptom which has been studied, again with rasagiline. We did a study in Italy, which is published on Neurology now, and just measuring fatigue in patients with Parkinson's disease. And we found that more than 30% of the patients suffer from problematic fatigue. And definitely we have no much armamentarium to treat fatigue in PD. So the only data we have is this sub-study of the Adagio, where we treated this early patient with rasagiline 1 and 2 milligram, and in both groups fatigue was improved. And in this study we used the Parkinson's disease fatigue scale, as well as we used for the Italian Forte study. The other question we asked in this year, does levodopa plus entacapone giving a better half-life, can this produce a better or more continuous delivery of the drug and avoid dyskinesia and motor fluctuations? This was the question behind the STRIDE-PD study. Unfortunately, we failed to demonstrate that levodopa plus entacapone is actually superior to levodopa alone in delaying dyskinesia. So unfortunately, if you use levodopa plus entacapone in the early stage, you don't reduce the risk of having motor fluctuations and dyskinesia. But something is interesting. You can combine the two enzyme inhibitors. So if you combine, for example, as we did in the Presto study, levodopa, rasagiline, and entacapone, you can have an addiction effect, a more efficacious treatment, so an add-on effect from rasagiline to entacapone, or from entacapone to rasagiline. So in patients which are not stabilized, you can use one of the two enzymatic inhibitors, one on top of the other, and still getting an improvement. So what about the new generation of enzymatic treatment? Well, the first one coming on soon on the market, almost everywhere is already on the market in Germany, in Switzerland, is safinamide. Safinamide is a potent, reversible monoamine oxidase B inhibitor with other pharmacological properties. It actually has an action on calcium channel and potassium and this actually can modulate the glutamate release. So it's a monoamine oxidase B inhibitor, but also is a modulator of the glutamate release. Safinamide has been studied in patients with fluctuations, and this is the 016 study, and we choose as a primary endpoint increase in on time, which is actually a more difficult primary endpoint to reach compared to the decrease in off time, because this has to be the good on, so it's on time without troublesome dyskinesia. So both doses, 50 milligram and 100 milligram, met the primary endpoint, and we showed that this drug can increase on time in fluctuating patients in two studies, actually, the 016 and the motion study. But this study was particularly interesting because was remaining in double-blind fashion. We carried on the study for 24 months. And after 24 months, still the improvement in on time was still there. So you see after 6 months reaching the primary endpoint and then maintaining this effect for another 18 months. But another interesting aspect of this study is that the primary endpoint of the second part of the study was changed, and we look at dyskinesia. And when we look at dyskinesia in all the patients, we actually didn't reach the statistically significance. I mean, there was a trend in reduction of dyskinesia on the scale, but was not statistically significant. So we performed a post-hoc analysis in just on the patient having dyskinesia at baseline, more than 4 at the DRS. So the patient with clear dyskinesia. And in this case, giving 100 milligram per day of safinamide, we had an improvement in dyskinesia, but not giving 50 milligram. So I want to be clear. This doesn't mean that this drug is an anti-dyskinetic compound. It's a drug that actually improves off time and improves on time, but there is a signal there. Definitely, the troublesome dyskinesia did not increase after 24 months. Plus, we have this signal in a post-hoc analysis that dyskinesia can improve. So this is something to explore much better, to design a trial for dyskinesia, and eventually we can establish if this drug really acts as an antidyskinetic compound because of the antiglutamatergic effect or not. So far, this is what we have. The other drug which is coming out is a new catecholomethyltransferase inhibitor. It's called opicapone. It's coming from a small company from Portugal. It's called BL, and it's already at the EMA. So we're waiting for EMA response in a few weeks. Opicapone is a very potent catecholomethyltransferase inhibitor. I would say close to tolcapone. So it's more potent than entacapone, a little bit less potent than tolcapone. Just to give you an idea, I'll show you some data. And it's a once-a-day dosing, so you give it once a day. It doesn't produce any liver toxicity. It doesn't produce urine discoloration. So it's a very interesting new compound, which seems to be very safe as well. There are two big studies, pivotal, called BPARC-1 and BPARC-2, one conducted in Europe, another one conducted especially for the American market, which is only versus placebo. For the European study, they used, in fact, entacapone as a comparator. And you can see here that opicapone 50 milligram was superior to entacapone in reducing off time. So this other study here is the BPARC-2, where opicapone was compared to placebo, and again, there was a statistically significant improvement with 50 milligram. And these are the two studies combined, where you have improvement with 50 and 100 milligram, 25 and 50 milligram of opicapone. But what is actually quite clear is that opicapone 50 milligram is superior to entacapone, even if entacapone was actually efficacious in this study, as you can see, versus placebo. The change in on time without troublesome dyskinesia, again, this is opicapone 50 milligram, and then we have entacapone, which actually was efficacious too, and these are the two studies combined versus placebo. And this is the long-term open label observation of the patient who actually participate to the trial. This is the first part of the study, with, which actually met the statistical significant improvement. Then, and this is placebo, then all the patients were switched to opicapone, and you see that in the placebo arm catch up, and they were well improved up to 365 days. So it's almost 1 year follow-up with a large number of patients. I think I remember it was about more than 80% of the patients participating to the extension trial. So in conclusion, enzymatic inhibitors, monoamine oxidase B and COMT inhibitor, are useful and efficacious in the management of Parkinson's disease. Monoamine oxidase B inhibitors can control Parkinsonian symptoms in the early stage of the disease and improve fluctuations in advanced patients, increasing endogenous and exogenous dopamine in the brain. COMT inhibitor improve motor fluctuations, optimizing peripheral levodopa plasma level and increasing bioavailability of levodopa. Safinamide, it's a new monoamine oxidase B inhibitor. Opicapone is a new catecholomethyltransferase inhibitor, and I hope both of them will give us opportunity to treat our patient better, because of course there are a number of unmet needs in the treatment of Parkinson's disease, and we still have to meet them. Thank you very much for your attention.